So we're going to talk about COVID, SARS-CoV-2 and COVID-19 infections in kids. So do kids get COVID-19? Yes. They are just as susceptible as adults because anybody who doesn't have immunity is going to get infection. So you can go to the next slide. So there's been two recent studies that I think are very interesting. One was a study in Chicago where when they were swabbing people for infection, so these are people who had symptoms, including kids, and they did viral loads. And so it was the first swab that people had for their PCR, and they also did a viral load. And the younger children were more likely to have higher viral loads in their nose and their nasopharynx than older kids and adults. So wow, they have higher levels of virus. But then there's data, and so there's a very large study from South Korea that looked at contact tracing of known cases, and it was over 50,000, almost 60,000 people, of which a good hunk of those were kids. And what they found was that the kids under 10 were not likely to transmit the virus, the SARS-CoV-2, and yet kids ages 10 to 17 were transmitting as easily as adults. So here we have some conflicting data. Kids have high viral loads, but the young kids are not transmitting. And I interpret that in several ways, but we'll go on to the next slide. So let's look at the reported cases of COVID-19 infection in children. So this is a little bit old data because it was April, but it's from the MMWR, where they looked at almost 150,000 reported cases, and only 1.7% of them were children, despite the fact that children make up 22% of the U.S. population. So that's really interesting. Why are kids not getting it? Are they not being tested? I think they are being tested. So why is that? Now, a recent study in Nature said that 20 of the 10 to 19-year-olds, 21% of infections, and anyway, were in that age group and had symptoms. So, well, and also maybe others are asymptomatic. So go to the next slide. So let's look at what we also know about hospitalizations and deaths. So this is as of July 22nd. This is the COVE Kid project, which actually we're participating in both the PICU one as well as an overall pediatric one. 77 deaths were pediatric out of the 144, and out of the 800, there have been 800 PICU admissions. So still not a big amount compared to all the adults. Now, some other data in the world, looking at a little more globally, there was one study that found, this is not up to July, but only 44 deaths among children. So they're not common. Deaths among kids aren't common. But during that same time frame, there were 13,000 pediatric deaths from other causes, all causes. So cancer, trauma, infants with newborns with congenital anomalies, you know, all other diseases. So still, when you look at it, the deaths from COVID are really not very many for pediatrics. Next slide. So let's look at what we know here. So out of our population, so this is we estimate that we serve 400,000 children in our network for the WVU health system. And to date, there have been 2,500 approximately tested, 67 positive, and we've had 2 admitted here to Ruby. One was in the PICU and fairly ill, on high flow, recovered, went home. The other one was on the floor, not here for very long, went home. Both were 15, and neither one are from Mon County. Next slide. So speaking of Mon County, how many have we had? So this is shared last week from the Mon County Health Department. From March to last week, Out of the 868 total confirmed and probable cases in Mon County, 50 were under the age of 18, or almost 6%, and you can see the breakdown. So the percentage is the total of the total number tested, but you can see the majority of the kids, half of the kids were 13 to 17, and then 6 to 12 and under 5. And I will tell you, I don't have the breakdown of who were symptomatic or not, but I do know that some of those kids were tested because of family members in the household, and some of those were asymptomatic. But unfortunately, I don't have that breakdown. So next slide. So here's the crux of the thing. Why are children less sick and have less symptoms, and are they getting infection less? So I do feel that the schools shutting down in March, kids going into quarantine, has perhaps disrupted some of the transmission, either to kids or between kids, or maybe in the older kids from kids to teachers and other people. Kids aren't going to bars, they're not going to gyms. They probably are now going to some restaurants and other things with their families. But I will argue that I think that I wonder if one of the reasons why we've seen less pediatric disease is because kids have been at home. Now, these are some of the theories of why kids may have less symptoms. Maybe there are less ACE2 receptors in pediatric patients, and the younger you are, so you don't have that receptor for the coronavirus to glom on and latch to. Kids frequently get the benign coronavirus, the common colds, and maybe there is some cross immunity, but so do adults. So I'm not so sure how much that really plays a role. But, you know, you do wonder if the adults who are doing really well and maybe have mild to relatively or asymptomatic disease, do they have higher immunity to these other coronavirus? So stay tuned on that, because I don't think it's simple. I think there's maybe playing a role of a lot of things. There is some evidence that recent immunizations may give a protective effect, and it seems that MMR is the vaccine protective. So if a kid is fully vaccinated at age 5, he's gotten 2 recent MMRs, one in the recent time and one when they were a year to a year and a half old. Maybe that's protective. And we do have a concern that there are less well-child checks and less vaccines happening, going on. And I'll answer your question, Ray, in a minute about comorbidities. So is there something about the pediatric immune system? Some have said, is it stronger and better suited to fight the virus? But I wonder if it's not yet sophisticated enough to mount a large inflammatory response, and that's why kids aren't really getting much at all. I don't know. And then are they just better equipped to fight off the novel pathogens? So I don't have the answer to that. I think it's very interesting. This is not a pediatric disease. We've had 2 admissions for peds, and we did have a third, but he doesn't count. He was a 26-year-old congenital heart patient, and he came in 3 weeks after he had COVID-19, and he wasn't really ill. So we've had 3, but he doesn't really count. Next slide. So there is this concerning multisystem inflammatory syndrome in children, now has been named this MISC, and they have symptoms of fever, rash, shock light, heart involvement, perhaps coronary artery involvement, many similar features to Kawasaki disease, and then they're getting treatment. They're getting convalescent plasma, which we actually, is called IVIG, and I think people have tried using aspirin, steroids. So some of the similar treatments, I really believe it's a different illness. It is a trigger of a similar inflammatory disease that looks like Kawasaki. The median age is 8, and it can be on up to 17, 18-year-olds. We all know that Kawasaki is generally a toddler, preschool-age child. So I think they're very similar. Whatever got the inflammatory ball rolling down the hill and out of control is similar to Kawasaki, but not the same. Now, maybe people will learn about what is the trigger about Kawasaki because of knowing that there is this association. And it is rare. There have been, well, I use that word victims, but about 1,000 who've been reported worldwide, a couple hundred out of New York and some other places that have published. And all the kids have association with having had a recent COVID-2 infection, so serology is positive, or currently they're PCR positive. And usually their COVID is not seem to be the problem, it's then this multi-system inflammatory syndrome. Next slide. So I think that we have concerns in children about adverse childhood events, these ACEs, and growing up with real stressors in the household, and could lead to further health problems. So now there's a worry about children for many ways: social isolation, school closures. What is the impact of what's happening in their household? You know, families who maybe have lost jobs, or who have or don't have food, and there's perhaps more abuse now, verbal or physical abuse. There's really worry that our kids are really missing out about school. So I'm happy to have a discussion about what my thoughts are in school. Now, getting to Dr. Leonard's question, there's two nice series of admissions of children in the United States, so we're talking 17 and under. And one was out of Philly and one was out of New York. And they both show that most, not all, but most have a risk factor, as we would imagine. Neurodevelopmental delay, having a trach, home vent, obesity, immunocompromised, and then under the age of 1 is another risk factor. So it seems to be the infants, and then children with underlying disease, and not a huge amount is yet published about cancer in children, although the one series out of New York had one death, and that was a kid who was end stage, who had no treatment options and were in remission, and so I think it was not clear from the article whether it was really COVID-19 that they died from. So the big question now is, what about schools? And I'll be glad to open this up for discussion, but I will say that I think the younger kids, you could think about safely opening schools, the preschool, elementary age, if they're less likely to transmit, even despite having a high viral load, and they're not really getting ill, then I think we weigh the risk-benefit. The benefits of them being in school are really much higher. Now, what about the over 10-year-olds? I think when there's a lot of COVID in the community, I don't know how you can safely open the school, because there's going to be the same amount of COVID in schools. And I did see a picture yesterday or the day before, I guess 2 days ago, of a high school in Atlanta or in Georgia somewhere, I don't know where it was, packed hallway. And from what I could see in the picture, half of the kids had no masks on. That doesn't feel good to me. Now, next slide, I think, just says questions. So if we even want to take the screen down, we can. Or anybody have a question? I'm open to have a good discussion now about what people think.
Thank you so much, Dr. Moffett. That was excellent. So we did get a couple questions in. Let's see. I also saw, Dr. Costello, I'm so glad you could make it. You don't need any introduction, but just as a formality, I do like to introduce you. So Dr. Lisa Costello is from the Division of Pediatric General Medicine and the West Virginia DHHR. So glad you could join us as well. And feel free to chime in with any questions or responses to questions. So the first question we did get in was, how can we protect our small children in daycares and preschools once their school starts? This individual has children 4 and almost 2, and you can't keep their masks on. So any recommendations to those?
Well, so I think the daycare age kids, I know what our daycare is doing here is the kids are not wearing masks. The workers are. They're screening very clearly at the door, and if there's any symptoms of illness or fever, they're barred from coming in until they're tested and well, or you know, and then the kids can come in. Now, that's one model to do it that way. I think that as children, I believe, I mean, my kids are now WVU age, but I know several people who have younger age kids, and they've really taught their kids and modeled their kids' behavior well about wearing masks and getting ones that fit. That's a really key thing about having masks that fit a child, and then colorful ones, or if people sew, or if you have access to someone. I think it's hard when you don't sew yourself, but have access to someone who could make masks that, I know one person I know has 3-year-old twin boys, and she made ninja ones and superhero ones, and her kids will not take their masks off. So I know I'm overgeneralizing because I think all kids are unique and different, and it is hard, but I think that the school age kids can be worked with to wear their masks. I think, you know, I think having, well, I just think there's 3 things that we know that work: hand washing, masks, and social distancing. So if you're wearing a mask and you're not able to have your hands on your face, and then you have a big pump bottle, or and you can hand sanitize and you can wash your hands, you're less likely your hands are going to your face, and you're not taking the COVID-19, the SARS-CoV-2 from your mouth to someone else, and vice versa. And Lisa, if you want to chime in, you work with general peds, little kids.
Yeah, I'm actually on the pediatric wards right now, so that's why I have my mask on, because I'm sharing a space. And very interesting, yesterday we had a 6-year-old girl, and as soon as we walked in the room with all of our masks on, she got her mask out and put her mask on. And then there was a mask that had been given to her, and she put it on her stuffed animal. I mean, it was just kind of, and I told the parents, I was like, good job. I mean, the parents didn't even have the mask on in the room, but the girl put it on, you know, and then wore it the whole time that, you know, members of our team were in there. But I think your points are well taken. I think an area that that AAP has tried to start emphasizing is that, you know, you can't just, and maybe Dr. Moffett said this in our last echo session, you know, you can't just try to do this the night before. We have to start with children to getting them to adapt to, you know, wearing a mask. I think adults have to. I've had to correct some of my residents to say, hey, put your mask on, you know, if you take it down to take a drink, like, you know, you got to put your mask back on. So this is something that's going to take time. And the AAP has said in those younger children, you know, focus on other measures. If you know, try to get them to wear the mask. If they're struggling with it, you know, work on it, but make sure you're really emphasizing the hand washing and making sure, as Dr. Moffett said, the adults around them are wearing it. And that modeling of behavior is really important. So I think it's been a challenge even with adults to get them to wear it properly. But I think children will model behavior of those around them and can be taught that. But it needs to, it's going to take time, and it can't just be done in one moment. So, but yeah, I agree with all of Dr. Moffett's comments on the school reopening. I think someone commented on in these other countries like the Netherlands and Switzerland and in Denmark and Finland, I think it goes back to that community transmission. If you're seeing high rates of community transmission, it makes it very challenging to feel safe to open some of these schools. I shared Dr. Moffett's opinion of, I think, focusing on younger school age, because at least for what we continue to find, they seem to transmit less and also seem to get less severe infection. I mean, we in West Virginia have seen some daycare outbreaks, and those children have done well for the most part. and there's been some spread, but by and large, we have had daycares be open to a certain extent for essential workers or what have you, and there's been outbreak guidance to that is available for that as well. So I think that focusing more on the younger population, and I think for the long-term benefits, it is more important that, for them, their development, getting them back to school, they don't change classes. What I've been hearing a lot from middle school teachers is there's no way we're going to be able to cohort them. They have to change classes. Where in elementary school, you're usually in one room and you can stay in that room. So there is a better possibility to be able to cohort those students.
Thank you. Those are all excellent points. So we got another question in. It is, do you feel that acute flaccid myelitis is related to COVID-19 in children?
Yeah, acute flaccid paralysis has been around. Actually, it really surfaced in the year that we saw the enterovirus D68 outbreak. And I don't even know that it was totally proven that all those cases were due to that strain of enterovirus. But we kind of saw a few cases, and now it's peaked again, and we're seeing more in this past few months or this past year. And so I have not seen any proof or even any association with COVID-19. And I do suspect that there's something else there. But I think that those cases, are reportable, and we need to look at what is the cause of this acute flaccid paralysis.
Thank you. Are there any other comments, Dr. Costello?
I think Dr. Moffett said it very well.
Absolutely. Awesome. So the next question we had was, while we don't have a lot of data on short-term effects in children, what are your thoughts on long-term genetic and system-related effects?
From COVID-19, yeah. I think we have to wait and see. There is a concern that a small number of adults continue to have problems with COVID-19, even when they've recovered from the virus. The SARS-CoV-2 isn't detected anymore, and yet they still have problems. Now, my understanding of that, now I'm a pediatrician, is that those are people who had heart involvement in the hospital, and they're still recovering. So it may take them a while. I've not heard of the same thing for children, and so I think it's going to take some experience with this. Because we have less cases in pediatrics, it's going to take a while until maybe you see a signal that it's 1 out of 10,000 children infected, or 1 out of 100,000 infected who develop something that might be different related. I think it's going to be interesting to hear what our sociologists and our anthropologists and all the rest of us find about what the impact of all of this is on our young population and society 5 years or 10 years from now. Are they going to be more resilient? Are they going to favor their family? And are they going to look back with fondness over the time they spent with their family, or are they going to look back and go, oh, I was with my siblings for months on end, or what are they going to look back on? I think that'll be very interesting. And I brought up that last slide I had about the ACEs. That's the real worry that we have, is that kids are the silent ones in our society. Old people have organizations who advocate for them. So do we. We have the American Academy of Pediatrics, but I feel at times that there are things happening for children that if they're not in school and they're not being seen, if they're not coming to well child checks or to their primary care, we're not seeing them. We're not aware what's really going on. And that has many of us very, very worried for children. Are they getting enough food? Are they getting their basic needs met? I have a colleague whose kids go to one of the elementary schools in Morgantown, and she was talking to their school nurse about what her thoughts were about reopening. And the nurse said, well, there's some kids who we buy underwear for at the beginning of the year because they come to school and they don't even have any underwear. So worrying about them getting their academics is sometimes the least of the worries. Is getting those kids in school and getting them engaged and getting them the proper clothing for them, and then meals, and some of those basic things that for our households we just take it for granted. And yet for pediatrics, we really worry. And I think it's not just the little ones, but it's all age. The kid who is very socially awkward and is better at home because they don't have to interact with people, and they then get to school and they then maybe blossom and bloom and make friends. But if you're missing out on 6 months or a year of being with your peers, what are they going to be like when they come back? We have those real concerns.
Yeah, and I would just add, I mentioned I'm on boards right now. We had a patient this week admitted for a suicide attempt, and she noted that it was the stress from COVID and the pandemic and being isolated from her friends that led to her. I think she already had baseline mental health, but just she noted that. I mean, she said all that's going on, and I don't know if any of our psychiatry colleagues are on, but there's been prior echoes that have spoke to that, and I think it's a very real concern from what Dr. Moffett spoke to in the young and adverse childhood experiences, but then also the mental health ramifications. The reports to our state DHHR has gone down in regards to abuse and neglect. And I've seen, people make the argument schools can't be our only safe house for that, but schools are an integral part of our lives and our culture, and they do play a role and really are a safety net program. And there was I think I saw it on a social media site of someone articulated that, of how many of our safety net program for children's have been weaved into the school. So when we take away school, we take away a lot of those safety nets. And that's been generations that have built it that way. So when we change it in an instant, it's hard to replicate those safety nets in other regards. So I do think the mental health ramifications and the development and the delays that we may see from that, as well as, we haven't really mentioned children with special health care needs who get a lot of services through schools, and disrupting their routine and the services for therapy that they get. Also, I think is for me a concern of what's going to be the long-term health. So maybe they never got COVID, but the mitigation strategies that were necessary, I think will also have an impact. So I agree wholeheartedly. I think time will tell, but I think we have to consider those secondary effects, even if the child did not get COVID, but just from all of the ramification from the mitigation strategies that we've needed to deploy and how that impacts their long-term development.
Right. So the frustrating thing that I have about the schools is no one that I'm aware of has been tapped into to be an expert as a pediatrician to work with the state guidelines or our county guidelines. However, there are two colleagues in our department who reached out to the Board of Education and were asked to be a part of one of the task forces. So they did review things and made a recommendation, but then our school board is closed in terms of then their discussion and then what they're coming up with guidelines. So I then do not know. The question was, what's the metric that's going to decide whether schools are open or closed? I mean, the governor said yesterday, I think, green, yellow, orange, red is going to, or actually it was the front page of the paper today talking about football. And whether the football games were going to go on, it would depend on how much COVID-19 was in the community that week and would determine whether a game was going to be on or not if they are playing. Well, how about let's bring a broader aspect and say what is going to decide about whether the schools go or not? And I've not heard any of that. I've not heard anything related to that, which is frustrating.
So I can speak to it if you'd like. I think I see at least one local health officer, Dr. Rexroad, on this has been vetted a lot through our local health departments and our local health officers, and I have been involved with that. And also, they did invite the West Virginia AAP. We have weighed in on the school guidance. Just like anything with advocacy, you know, we make suggestions. I can't say they all have been implemented, but I would give it to the State Board of Education that they did take a lot of the suggestions that were offered by some pediatricians, and Dr. Weiss actually looked at the guidance as well and did weigh in some. But the alert system that the governor referenced is based upon a few measures, and it's still, you know, it hasn't been released to the public, but things could change, but at this moment, these are the measures that are being considered when we're talking about the alert system. It would be obviously looking at the incidence of the new cases in that county. I can share a link that anyone at this moment can look to see what the incident rate is. It's calculated using a 7-day rolling average per 100,000 population. I think it was Dr. Rexroad who brought up, you know, many of our counties in West Virginia don't have that type of population at a county level. So there are efforts to look at what does that mean when it's you're dealing with a smaller community that maybe only has a population of 10,000, and how does that impact those numbers? And then the percent positivity, so looking at the positivity rates among those who've been tested, and also doing a 7-day rolling average based upon that. Looking at the hospital admissions in that area. So again, this is mostly based upon a 7-day rolling average. So what is the amount of hospital admissions in that area? And then also looking at congregate care settings. So is this spreading in a broader community setting? So there were times within our outbreak in West Virginia, there were counties that looked like they had many cases, but it was all within one prison or one correctional facility. So I think it's important, that's why that was taken into account, so that it was determined to look at what is the you know, where are these diseases happening? Is it more in the community setting, or is it more in a congregate care setting? And so those measures are all what are being used to look at what would determine if you're at a green, yellow, orange, or red level, and then working with the local health department to determine, you know, what type of, looking at what mitigation strategies are already in place, and then looking at what potentially would need to be deployed. And the alerting system has been talked about also being used in nursing home settings or other congregate care settings. And this is complicated stuff, so to make it be simple that people can understand, I think has been one of the biggest challenges, because even talking amongst, you know, clinicians or other individuals, it's a lot to consider, and there are lots of models, and we've talked a lot about modeling in prior echoes, so I won't kind of get into that, but that's kind of the current design of the alert system that would look at, so it's looking at multiple items, which I think is wise, because I think it's hard to just solely look at one factor, and we're really trying to determine what is best when you're looking at the overall county, and it certainly does change depending upon where you're at for various reasons, like I mentioned. So hopefully that answers the question, but that is the alert system that is close to being launched, and there has been multiple physicians who have been engaged in that discussion, and the local health officers as well have weighed in substantially.
Thank you both. We got another question in. So what do you think about the contact tracing model used for adults in tracking contacts for children at school? Should we use a different model?
I don't think there's a reason to use a different model for tracking. And hopefully school, you have an idea, well, at least with the younger ones, of who they're in contact with. you know, they're in their classroom. Now, the older kids, if they're changing classes, then I think that's a little more challenging.
Yeah, I think, you know, I help lead a course for contact tracing through our School of Public Health. And if you haven't researched the National ASTO model of contact tracing, it does a pretty good job. I don't necessarily think it needs to be different. I think it's just like anything when we work in pediatrics, you have to use from those around. That's why there has been discussion about in schools keeping a log of who is in what classroom at what time, and most attendance logs, which, you know, attendance, unless they've stopped taking attendance in school, that's what I used to, you know, needed my personal pan pizzas, that and reading my books. So, I mean, I think attendance will be documented in that way. And so there will be able to be that contact tracing. And we've had to do contact tracing for daycare outbreaks that we've seen. I mean, we have had pediatric cases. Dr. Moffett penned a very nice piece with her colleagues, Dr. Gupta and Weiss, that was published in a national forum. And, you know, I think, you know, we know that kids get COVID. I think it's just, you know, all the points that Dr. Moffett spoke to. And so we have been doing contact tracing and using those methods, and have already had a past precedent to do so, whether it was daycare or with a sports team or at a camp setting. And I think it can be a little bit more challenging because obviously the child might not be able to tell you as much, but I do think the process is the same regardless of the person's age.
So there was a chat comment question about what if you're able to provide food at home and you feel you can do learning at home? You know, what's my opinion on that? So this is what I've said to my family, my patients, my families, the parents. I think that whatever decision they make is the right decision for them, because there isn't a clear answer on a lot of these things. What is safest and right for your child, for your family? And if you are comfortable with your kid going to school and knowing there's a risk they could get COVID and be okay but sick, and you could get it and be sick but okay, then you know, okay, you send your kid. If you live with your parent or an elderly person who's in their 80s or 90s in your home and you really don't want COVID coming in your household, well, then that's a different situation as well. But I think that for any family, the parents, I think then what decision they make is the right one for them. Now, and I think that may change, you know, so they may make one decision and then may change based on what we know and what further information happens. Now, one thing that I do wonder, that school's open and we find out how many kids are coming, well, maybe it would be easier if the class of 24, only half those kids are coming. Then it's easier to social distance in the class of 12. So I don't know that I know how many parents have really made the decision to keep their kid home. I don't know, Lisa, have you heard anything about that? Because I certainly haven't.
I think it's, from what I'm hearing from most.
Oh, you're muted there, Dr. Costello.
Sorry. That's impressive that you could tell even with my mask. I don't think I've heard final numbers, because what I've been hearing from parents, at least, I think they had until this week to make that decision, and many people were still trying to figure out what they were going to do. And so I don't think there's concrete numbers that I'm aware of yet. Anecdotally, I do think I've heard more people say that they're considering that, but I agree with Dr. Moffett. I take that approach as well, that I think the decision you make for your family is the one that's best for you. It's just everybody has different circumstances that have to be considered.
Right.
Thank you. We did get a question a little bit earlier saying, I have a 15-year-old stepson who's unvaccinated and due to come to my home in less than a week. His mother took him to OBX in Myrtle Beach this week. How concerned should I be about his return to us?
Well, I was personal messaging that person but I'll answer what I said because it's not. It's that I would be a little worried. I mean, are you prepared that COVID could come in your household? Now, it's not just Myrtle Beach and Outer Banks. It could be Morgantown, or it could be anywhere. You know, how careful were they? How safe were they? And are you prepared for the fact that you come back from somewhere and maybe you were in a higher risk area and now you have COVID? So I think understanding, were they wearing masks all the time? Were they not eating out in places? They're getting takeout. They're not being in crowds. And then if you come back and you really want to quarantine, you know, what we're saying is 5. So if I have a known exposure to COVID, but I don't have symptoms, it's 5 days of quarantine and then masked for the total for 14 days. Now they're going to maybe be in the same household. So I think you have to figure that out. Are you going to be able to wear masks in your house or be in separate parts of the house and try and social distance within your house? So I think those are all very real concerns. And yet we know that we want to see our families, and kids want to see the other parent. You know, when there's blended families, and summer is the time to do that. So I think it's a challenge.
Thank you. The next question we got was, any thoughts on how a school or school health center should handle a case of symptomatic student who is awaiting test results? The student should quarantine. What about students or staff she or he may have exposed?
Well, so if that kid is a PUI, has symptoms and is a PUI, they need to be at home until their test is back, so you know the results of their test. And then if they are positive, you know, the guidelines have changed a little bit. We don't need 2 negative tests in order to return. The CDC guidelines are what we follow now here at WVU Medicine, that if you're 10 days from the onset of symptoms and you're better or you're asymptomatic, you can be back. If you've had no fever now for 1 day, 24 hours with no antipyretics, and your symptoms are improved to really be improving, and it's 10 days, you can be back. If you're still sick after 10 days, you need to not come back until you are better. But 10 days is kind of the time when, for most patients in the hospital, they can be taken out of isolation. Now, we do say at Ruby, and I think this will be all of WVU Medicine, if someone is still really ill, has a high oxygen need, then they may stay in isolation longer. But that wouldn't be for the outpatient person. So what do we do about their contacts? Well, this is part of the contact tracing. And if they were in contact with someone who is asymptomatic, you know, do you quarantine for 5 days and then come back? Or do you wear a mask all the time and hand washing and knowing that you can still be in the setting and monitor for symptoms? And any symptoms, and it's not just fever. Because remember, only 40% of people with COVID have a documented fever when they get sick. So using fever as a screen is okay, but it can't be our only screen for symptoms. So it's cough, losing the sense of taste or smell, headache, achiness, perhaps some GI symptoms and diarrhea, chest pain, shortness of breath. I think you all know this. Lisa, do you want to add anything on there?
Yeah, I think it's tough. I mean, the way contact tracing works is that until someone gets that positive, it's hard to truly, you know, that's when the process starts. So I do think it's challenging when we're talking about this PUIs, you know, what do you do with the contacts of them? Because there are going to be other viruses that go around. And I think that that is going to be a challenge in children. You know, my friends who have, you know, daycare child's age, they're like, you know, my son had a stuffy nose the whole time he was in daycare. I mean, that's just, you know, and that is a symptom. So it is, I think, going to be challenging as we get into RSV and flu season. to even further make that distinction, but we'll probably have to err more on the side of caution. So I think emphasizing what Dr. Moffett did, making sure wearing the mask, washing the hands, maintaining that distance. If there was, to me, I mean, the symptomatic patients are a no-brainer. I mean, if you're having symptoms, you need to be quarantining until, if you're positive, that then you're isolating. I think it gets a little bit more challenging in the asymptomatic individuals. And, you know, obviously if they weren't having symptoms, they wouldn't have been, but, you know, the asymptomatic is what's been the challenge, I think, with this, one of the challenges with this virus.
So some very interesting data that has come out in terms of looking at the testing for COVID, or for SARS-CoV-2, is, you know, the gold standard is the PCR. And what we know is it can be exquisitely sensitive and finding, you know, be positive even well after a person's symptoms are gone. That's why we're not requiring 2 negative tests now. But people have looked at the viral load and the culture of the virus, and then the number of cycles of PCR that it took to get a positive. So, you know, just understanding how the PCR is done is that they amplify. So this is an RNA virus, and then they transcribe, and then they amplify the DNA, and then they do the PCR. So how many cycles does it take to get there? And it can be anywhere from like 10 to 25 to 35 cycles. Well, what some of the stuff coming out has shown that if you look at the viral load and you look at finding the virus, once you go past about 10 or 15 cycles, then those positive PCRs are not viable virus. So, so what it means is, and it's usually those who are asymptomatic. So we have an incredibly sensitive test that's finding people who really may not be contagious. But the trouble is our lab doesn't report how many cycles did it take to get the person's positive test. But there are some other tests that are much more rapid, that are a little less sensitive. So the argument I've heard is that for the outpatient anyway, those who are symptomatic are in that group who have virus there, and they'll be positive on those quicker tests that are less sensitive, because the ones who have the takes longer on the PCR to get a positive are asymptomatic. And is it okay to have a negative test because maybe they'll be not contagious? And I think it's a different way to think of it, so that those who then really have that positive test, they need to be quarantined. We need the result like this, like not even 2 days, but like 2 hours. And that then, when you argue that, a quicker test that's cheaper, we may give up some sensitivity, but we really need to get those people in and out of circulation. You know, I heard of somebody who had a test done on July 27th, and they're still waiting on the result. That's ridiculous. You know, that's just ridiculous. So that person cannot, you know, will not quarantine probably all that long if they didn't have symptoms. I think they were part of some screening, but still, it doesn't make sense that if they're positive. So anyway, I think we have a lot more to learn about this, but it really makes you think, if we could have really rapid tests where, you know, I get tested now, and by even before the end of the afternoon, I know I'm positive, you're out, you're home, as opposed to me waiting until Monday, and maybe I was like, oh, I'm okay, I'm going to go out, or somebody's going to stop at my house or whatever. No, I would be likely to not do that if I knew I was positive. So maybe that will help to answer these questions about these asymptomatic shedders. I really think they're probably not very contagious. Maybe they're a little contagious, but by wearing a mask and washing your hands, if you feel well, you may not spread it.
Right,
you know,
and the only other
that chance, but it's interesting to think about anyway.
Yeah, and I think to really highlight the point that Dr. Moffett made about not repeating the test. I mean, we have seen people test positive for weeks and months. I participated in a call with the CDC. You know, there's been this question of, is there this reinfection? And the CDC, you know, when looking at it, they have 0 confirmed reactivated cases. There was question in West Virginia, you know, someone had tested negative and then they were tested after that and they tested positive again. So was this reactivation? And those cases get looked at CDC. And when we met with CDC, there had not been any confirmed cases. Now, in prior coronaviruses, they have seen the possibility that you could potentially be reinfected, but I think it's going to be a big question. You know, to me personally, I don't see the utility of retesting someone within 12 weeks, the CDC, because then if they become positive, what do you do to interpret that result? We have, as Dr. Moffett just articulated, we don't feel that they're infectious. And so in a limited resource of a test, you know, why are we utilizing testing in people that we already knew were positive, whether it's for employment, or now we have higher education testing coming back. So we're going to be potentially testing students who had already tested positive, and we know that. And well, it's just easier to retest everyone. I'm not sure that's a good use of a limited resource, because it's not going to lead to further public health intervention. I actually think it's going to add to the caseload, because they're going to pop positive again. And it's like, well, yeah, we knew they were positive, and we can see that they may test positive again. And as Dr. Moffett said, we're not reporting these CT values. And so it's hard to then interpret that. And then I think it leads to, you know, a lot of confusion, and can potentially lead to undue fear when it shouldn't exist. So I think that, you know, I see that as a potential issue more and more as we know that there's more positives in our state. And then you're exposed, you know, well, you were already positive. You know, I don't know if Dr. Moffett or somebody else that's maybe smarter what they feel about it, but and the CDC says, you know, you should not retest those individuals within 12 weeks.
Right.
But
there's a comment on the chat about nursing homes are regulating that they have to retest their positive residents. So I can feign ignorance because I'm a pediatrician, but I think I've read enough, and just like Lisa, to say that it's hard to interpret those positives. So I know someone here who was positive in March, finally got tested when we had testing, and she had 5 swabs done. 5. And now, you know, we would have had done 1, and then when her symptoms were better, she would have been back at work within 10 days. So that's, you know, we have limited swabs. We really do. We still have limited testing and limited swabs. So in most of the time, I think, not retesting. Now, I'm not writing the nursing home regulations. So Lisa, you want to comment on that?
No, I think it's an ongoing challenge because of what we're doing, because there's policies. I mean, right now there's a lot of higher education. I mean, we know that there's been college students who have been positive, and, you know, and I'm finding that, you know, they still have to get retested. And it's the same thing with the nursing home or daycare, or I think when we get into the school discussion, you know, if a kid is tested positive and then they go through their routine, you know, isolation and all of that, and then they're deemed an exposure and they want to get everyone tested, again, I don't see the utility in that. And so unfortunately, I think sometimes people do it because it's quote unquote easier, because it is such a small percentage when you're talking about, you know, a larger number. But as we move forward in this pandemic, I do think we need to have further discussions of, I don't really think there's utility in doing that. I think some in the nursing homes, you know, some of it is, you know, well, how long are they still testing positive? And my answer to that is that's why we do studies, you know, to do that thing. I mean, we do get information to see, because we can now say things like people have tested positive for this long period of time because they did have to have that repeat testing. So we learned a lot of, you know, because I've heard many examples like Dr. Moffett has shared where you have to be tested multiple times to then get that negative. So yeah, I think it's tough.
Yeah, and our policies keep changing. I mean, you might look at that as being annoying, but actually we take a policy that we have and we're in the process of updating our back to work policy again because of the recent CDC update. So the person on the call, who's on the chat, running into employers who are insisting on a negative test, go to the CDC website and print that out and send it to them, or send them the link, take them to that page to say, this is what the CDC says about employees returning to work. So I think we have to work within our system that has regulations, but we also have to know that this is changing. And that's why you're on here, because we're trying to help. And I try to stay as up to date as I can. And I appreciate Lisa clarifying what I said about schools, because I didn't know. But there's other things that I am keeping up to date on. So it's challenging, and we have to work within our system. But when there's new data that comes out, I think, you know, CDC is very helpful. It's very clear on their website, and we should be following it.
Thank you both. We only have about 4 minutes left, which I think unfortunately means we only get one more question in. So the last question we have is, if there is an effective vaccine available next year, what population of pediatrics should be prioritized to receive the vaccine?
Yeah, I think that's a good question. Well, I think healthcare workers and, you know, are ones. I think our vulnerable population. So we look at how well will it work in our elderly, and then in our immunocompromised, and then looking at pediatrics. What are the studies done in peds and the safety? I think I've already gotten questions about that. I think we need to look at how the studies are done. But then I think we probably will look at it's going to be tough, because our kids, predicting which ones of our kids, I think we look at the risk factors. We know that. But it might be that pediatrics is not going to be on the priority list of vaccinating first. It may be their parents and their grandparents. You know, I think we have to wait and see. I'm all for vaccination, and I'm not saying not to give it, but I hope we have enough so that we're not going to be left with, I have 10 doses and I have 1,000 people, I have to decide who's getting it. Hopefully it won't be that bad, but it's going to be a production thing. Getting, you know, I think the two companies have each been given $1 billion and to look at clinical trials, conducting their clinical trials, because they're expensive to do, and then also looking at production.
Yeah, I think it's a great point. I mean, for me, it's going to be the studies for us who do pediatrics. I know there's some people on the phone who do or on the call that do pediatrics, that don't. Peds are usually the last that something gets studied in, and I mean, that's for good reason most of the time. But I think that we really have to look at the studies and who they were done on, and until there's evidence to support its safety and efficacy in peds, we're going to have to wait for that. And I think I've seen some pediatricians say that, and I think that's going to be frustrating to the public, because a lot of this is, you know, in the weeds science, that this is, you know, so many people are interested in science more than ever, but it is complex. This is, people are seeing science kind of play out for those who have studied it, but the general public, it's sometimes hard to, I think, articulate that. And when it comes to vaccines, there's already been so much prior misinformation that we already knew existed. It adds a level of complexity on top of it that I think is going to make this challenging, you know, comparatively to like H1N1, where we already had a conduit for we had a flu vaccine that we could then adapt, and it was studied in children, and you could give it to children, whereas this is a completely different vaccine that's, you know, we haven't had a coronavirus vaccine. So it is a different kind of messaging, I think, but it is it's going to be, I think we've talked about this on the last one, it's going to be challenging because of the misinformation that's already unfortunately out there.
I've heard two misinformation things, which is so disturbing. One of them is too ridiculous, that we're all going to be chipped, which I don't know where that comes from, but that's ridiculous. But I've heard that over and over. But the other one that I was asked last week, I was on a call with Congressman Mooney from the 2nd District on his town hall, and one of the callers said, is this going to be mandated for our kids to go to school? And I said, well, no. You know, and I kind of described the process of how vaccines are decided by DHHR, and it's not legislative. And I said, I think it's too soon to even know how we're going to be giving the vaccine. But it really made me think, are people already negative about a vaccine because they're afraid that it's going to be forced on them? And like Lisa said, it's about education and it's about benefit and demonstrating safety and all of that. But so we got some work to do, because you'd think everyone would want the vaccine. I remember that H1N1 year, people were clamoring when there's going to be a vaccine, when there's going to be a vaccine. And then we finally got doses in, and a few doses, and people were mad because they couldn't get them. But then when we got more doses in, people were like, oh, I don't want it. I'm like, the same people. So it's going to be some work to figure that out. So we will.
Thank you. So unfortunately, we're at the end of our session time. So I want to give a big thank you to Dr. Moffett for that excellent and super timely didactic. I also want to thank Dr. Costello for also answering those questions as well. Just one quick housekeeping announcement before we part ways. Our next session will be on August 20th from 12:15 to 1:15 p.m. We did get a few recommendations and requests for a didactic topic next time, so keep an eye out for that reminder, and we'll be announcing that shortly. So thank you all so much for joining. We'll see you guys next time.
Thank you.